What is state of the art for diagnosing ADHD? What tools do we have to make this assessment? There's not a brain scan, a blood test, an x-ray. So what is the best that we have available today to accurately make this diagnosis? Dr. Manos.
You've said it completely accurately in that there isn't any high-tech method for diagnosing ADHD, and I think that's a very important point to make these days. So what are we left with? We're left with Broadband rating scales. These cover a variety of symptoms, behavioral symptoms, emotional symptoms, and the like the Achenbach Child Behavior Checklist. You have narrowband scales. These are symptoms specific to ADHD.
Rating scales.
Exactly.
Rating scales.
Rating scales. The ADHD rating scale, for example. The Vanderbilt scale is a popularly used one. And the Conners scales are also used.
Anything besides rating scales?
Absolutely. There is something important about the use of rating scales, however, that should be kept in mind. And that is, you don't get rating scales just from the parents. You have to get them from multiple observers. So usually for children, that means the parent and a teacher, and for adults, it means a self-report from the adult and somebody who knows that adult very well.
Why is that an important point to make?
And preferably somebody who's known them for a long time. Well, for an adult, there is no adult onset ADHD. And for an adult whose symptoms started when they suddenly turned 50 years old, in the absence of somebody telling you, no, these symptoms have been there all along, you have a doubt in your mind as to, did these symptoms just start when the person was 50 and is now experiencing some kind of trauma in their own life or change in their own life, or is this actually symptomatic all through life?
So state of the art in your practice is the rating scales.
Well,
rating scales and from multiple sources.
No, the thing that is essential in a diagnostic assessment that I don't think you can leave out at all is a semi-structured interview. Now, there are structured interviews like the C-DISC, and my colleagues, I'm sure, have used them in some capacity in clinical trials, but most people in practice don't use a structured interview. But a semi-structured interview and a mental status exam are very important. They cover the gamut of disorder, and they also give a real reflection on what's happening throughout the child's life.
Clinical interview.
Or adult.
Rating scales. Dr. Goodman, expand on that, please.
Well, it's important that symptom checklists not be the sole determinant of treatment. That is, you do need complementary information. For adults, there are some adults who are very insightful to their symptoms and are very clear. There are other adults who get dragged in by their spouse and says, I don't know why I'm here, and the wife says, well, let me tell you about what he can't remember, what he can't do, and he's so disorganized. So for that patient who lacks the insight, a symptom checklist by the patient is not going to be an accurate way of determining treatment.
And you've got two checklists sometimes side by side that look very different in response from the spouse and the observer.
Exactly. Now, clinicians who have very little time, though, and listening to this need to know, well, how do these guys execute this in a time-efficient fashion? The patient fills out a symptom checklist, if it's an adult, in 60 seconds. You give a copy of that to give to their spouse, who sends it back to you. It really takes very little time, and the response rate from the outside informant in our practice is over 90%.
Beautiful. Any other objective measures that we have available today?
Well, I don't know about objective measures. I mean, as I'm listening, and I think all those tools are critically important, but day-to-day in clinical practice, we're using what doctors have used for decades as a clinical interview. I mean, when we diagnose ADHD, I think the tools are absolutely adjunctive in nature. But when a patient walks into the office, some people will give tools, some people won't, but we're going to talk to the patient. So we're going to get information.
Well, that's what I mean by a semi-structured interview.
Right.
So
That's the interview. But, you know, in response to your question, continuous performance tests, for example, have been used, and there are certain neuropsychological assessments that measure attention, or an IQ test. For example, the WISC has a subtest that is a measure of attention. And there are some sophisticated, in fact, I recall using one of the very sophisticated methods through, in continuous performance. I think it was developed in your arena.
Dr. Marty Teicher at McLean has developed a technology now called the quotient, which I think of as sort of a fancy upgraded version of a CPT, of a continuous performance task, where the patient is seated at a computer doing an intentional task on the computer while there's motion analysis cameras assessing movement to look at some of the impulsivity and the motion that can be quite subtle, particularly with adult patients with ADHD, that we might not pick up with the eye, but those repetitive movements, the drumming of the fingers or kind of bouncing of the leg, shifting a little bit. That quotient is available currently in limited parts of the country. My understanding is that they're looking to expand, and that it has been FDA approved as an adjunctive tool for diagnosis. So not a standalone, this isn't a doc in the box, go get your ADHD test and it's a yes or no. It's meant to be used in context of the clinical interview with the rating scales. And I have started using it in my practice quite successfully, very, very specific cases where having more objective information that's been helpful to me.
Now, many of these, though, are rather sophisticated, so they're going to be limited in their availability and utility in a primary care office where people are really seeing patients rather quickly and need to get a down and very concise evaluation of what's going on with the patient. I know that we rely on patient reports and clinical interviews. I will tell you in my own practice, though, because of the contrast effect between being on medication and being off medication and then being on medication, the patient comes back and says, this is life-changing, it's bread and butter difference, and thank you so much. Then they come back several months later and they say they think it's wearing off. Well, it may not be wearing off. It may be that the symptoms were there. They're now more aware of them. I find, going back to the symptom checklist, in contrast to what your impression is in clinical interview, you'll find that from the symptom checklist, the patients will score those symptoms higher than what your impression was in the clinical interview. And I keep going back to this.
So it's an important distinction. You're diagnostically using rating scales, but also in follow-up for your medication management and titration, you're using rating scales repeatedly.
Correct.
Got it.
Will you adjust their dose then?
I do.
So
I
if
will
they
adjust
have
the
a
dose
shift-
depending on symptom reduction and try to reduce the symptoms as much as possible.
So what about future possibilities with objective measures? Comments? What's coming down the pike?
There's no question that the future is in the genetics of ADHD. There's no question about that. High-tech imaging techniques are not likely to replace that arena of investigation because our findings of relationships at the synaptic level, of what occurs actually neuronally, and the genes that govern those are expanding daily. Now, just as a simple example, in the coloboma mouse, the SNAP25 gene is missing. Subsequently, you don't have migration of vesicle to the synapse.
Could you better define that, speak in English for those viewers who are not basic scientists?
Yes. There is at the synaptic level, neurotransmitters are migrated to the presynaptic membrane and suffused into the synapse. So you have a strong signal. In the coloboma mouse, the vesicle that stores the neurotransmitters doesn't migrate.
Can we apply that to humans now, Mike?
Yes, it's the same thing. It works the same way. So dopamine isn't as available. And if you inject a coloboma mouse with methylphenidate, nothing happens. The coloboma mouse is still hyperactive. You inject the coloboma mouse with dexamphetamine, now the mouse is
so
calmer.
You're giving us a scientific model as to why to pick between an amphetamine versus a Ritalin-type stimulant.
Well, no. The point I'm actually making is that when you can identify a gene that governs a synaptic action, then you're able to identify who's going to respond to what, which is what we all want to know.
Better prediction of treatment outcomes.
Yes.
And I would caution, however, that as promising as genetics work is in psychiatry, it remains the holy grail that has also remained very elusive. The studies for schizophrenia, for bipolar disorder, for major depression, for ADHD, and even for autism, in most of the autism cases, still is very elusive. So I would caution us that it's exciting emerging research, but it's not ready for prime time for primary care.
Exactly.
State of the art today. State of the art today. Clinical interview, rating scales, information from observers. So when you're getting rating scales, getting information from a spouse, or in the case of a parent for the child, some form of Neuropsych testing may be helpful for attention and concentration, such as a continuous performance task, how someone can pay attention at a computerized test of attention. And thinking towards the future, we're looking at a world where genetics may help guide treatment in ADHD.